So let's talk about the first and a very important factor of substance use disorder, which is biological factors. Now in biological factors, the first and very important factors are genetic factors. Does genetic factors play a role? Yes, they do. In fact, it is seen, and there is a strong evidence from studies of twins, adoptees, that indicate that cause of substance abuse has a genetic component. And the initial researches have shown that there is an association with gene that relate to dopamine production. Again, dopamine is one of the important neurotransmitters which we'll talk about. So yes, genetics do play a role. It has been seen from various studies, and the role of genetics we'll talk about separately when we'll discuss the substances independently. So we'll talk about what genetic factors or what genes are being proposed for which substance. We'll talk about them separately. And again, it is very important nowadays. Earlier there was a concept, nature versus nurture. So, genetic factors versus environmental factors. But nowadays, I'm sure you would be reading now, there is more of, the theory is more postulate. There is a gene environmental interaction which subsequently leads to certain disorders. So yes, genetic and environmental factors, they interact to lead to these disorders. So genetic factors play an important role. Second, and a very important topic which we'll talk about in the biological factors, are the neurotransmitters and neuroanatomical pathways. Now this is something very important. We'll talk about some important concepts. So I want you to understand also, and then also when you're writing an answer, you can write some of the important points. But understanding is very important. So let's talk about these important factors. Now, if somebody asks you which are the primary neurotransmitters which are involved in substance use disorder, so again there are various neurotransmitters, but if you're asked to name some of the important ones, again this is from Kaplan and Sedok CTP. It mentions opioid, catecholamine, especially dopamine, and gamma aminobutyric acid, that is GABA. These are three important primary neurotransmitters which are implicated for substance use disorder. Of course, other neurotransmitters are also there, but if somebody asks you the most important, these are the most important. So opioids in the form of endogenous endorphins are there, then dopamine and GABA, which is basically an inhibitory neurotransmitter, and we will discuss the role of some of these important neurotransmitters. Now, when we talk about the neuroanatomical pathways, we'll discuss about some important circuits. First important circuit which we'll talk about is the impulsive compulsive circuit. Now, these are basically hypothesized circuits which have been postulated to lead to these disorders. So we'll talk about what is an impulsive circuit, what is compulsive circuit, and how they are related. Second, and a very important pathway, and I'm sure you must have heard of, you must have read this, the brain reward pathway, or you can say the mesolimbic dopamine pathway. So this is the final common pathway for all these important substance use disorders. So this pathway basically, it begins from VTA. VTA is the ventral tegmental area. So from the midbrain, from the VTA, it goes to the nucleus accumbens. So this goes to the nucleus accumbens. In fact, this pathway we have also discussed when we talked about schizophrenia. So this pathway again we'll talk about here as well. And in this pathway, it is seen that there is increase of dopamine that leads to subsequently these disorders. Then there is another third important neuroanatomical area, which is again as mentioned in Kaplan and Sedok, locus coeruleus. Again, it is a largest group of adrenergic neurons. Again, it is seen that it may mediate effects of especially opioids. So this is again one area you can remember. But again, more importantly, we'll talk about these two pathways. Now let's talk about impulsivity and compulsivity first. Now first, please understand, these have been proposed as endophenotypes. So this has been proposed that these may be endophenotypes, and symptoms, some of these symptoms, impulsivity and compulsivity, they may be linked to particular brain circuits. So now you're seeing, in psychiatry, there is more going towards the dimensional field. So we're trying to identify certain dimensions. So it is, postulated, it is proposed that these may be certain dimensions. So impulsivity as a symptom, which is, proposed to be related to a circuit. And again, this can be seen in various psychiatric disorders. It can be seen in antisocial personality disorder, or it can be seen in impulse control disorder. So it is one dimension or impulsivity as a symptom. Again, compulsivity may also be seen in various disorders, such as it can be seen in OCD. So this is what is proposed, and subsequently these are seen in various psychiatric disorders. Now let's try to understand what is impulsivity. Now impulsivity is predisposition towards rapid unplanned reactions to internal or external stimuli with diminished regards for the negative consequences of these reactions. Suppose you've come from your OPD, you've gone to your mess, you've eaten your lunch, and you've come back to your room for rest, and suddenly there is a pop-up message on your phone from, let us say, one of the dining apps or food delivery apps such as Swiggy or Zomato, and that is offering your favorite pastry at a very discounted price within 10 minutes. So what do? You just order it, and it comes and you eat. So this is something which you have done out of impulse. So this is if you can correlate, this is a rapid unplanned reaction to, here it was an external stimuli, and also there was an urge that it is my favorite pastry, and without regard to the negative consequences that you're already full. So but still you have ordered. So this is what is impulsivity. So just to make you understand, this is impulsivity. Then what is compulsivity? Let's try to understand. When we talk about compulsivity, it is performance of repetitive and dysfunctionally impairing behavior that has no adaptive function. Suppose now what you do is you've ordered one pastry, now you've ordered another pastry, then you've ordered another pastry, and you continue doing that. So now what you're doing is you are repeating behavior again and again, and it is dysfunctional, and this behavior has no adaptive function. So this is compulsivity. Again, if you see both of them, they fail to control the responses. So this is impulsivity and compulsivity. In a more simplified manner, you can also understand it like this, as mentioned in Stahl's psychopharmacology, that impulsivity is inability to stop initiating an action. So you were not able to stop initiating, so you just ordered it. So that is impulsivity. And again, you take action without thinking, without a forethought. That is impulsivity. Then what is compulsivity? Compulsivity, in a very simple language, it is inability to terminate an ongoing action. So here action is inappropriate to a situation and you continue doing it. It becomes like an habit. So that is compulsivity. Impulsivity, when you're not able to stop initiating any action. Compulsivity, when you're not able to terminate an ongoing action. So this is impulsivity and compulsivity. Now, before coming to the circuit, let's again understand one very important concept which we have discussed even in other disorders. That cortex, again, it is believed that cortex, it has a top-down brakes. So cortex applies brakes. So there is, it for managing or for balancing, it, inhibits. While the limbic areas, there is a bottom-up drive. So there is a balance between them, and then we are able to do all our activities routinely. So this is the normal balance which is seen. So cortex, it applies brakes, and it is the limbic area which gives a drive to do any task. And the balance leads to the normalcy. Now sometimes it is seen that there may be too much bottom-up limbic emotional drive. So there is excessive emotional drive may be there, that may lead to certain abnormal behaviors, abnormal actions. And there may also be, sometimes it may be that there is too little top-down cortical inhibition. In fact, we have talked about this when we talked about Alzheimer's. In Alzheimer's, the top-down inhibition because of degeneration of the GABA neurons, the interneurons, there was decrease in inhibition. So that leads to in Alzheimer's disease, we talked about agitation. Similarly, even in ADHD, there is again a decrease in the top-down inhibition, and that subsequently leads to impulsivity. So here also, so because of too little top-down inhibition or too much bottom-up limbic emotional drive, it will lead to some of these behaviors. So if we have this concept in mind, let's now come back to the impulsivity circuit. So let's first talk about the impulsivity circuit. Now impulsivity circuit, this is centered on the ventral striatum, And in fact, this circuit is what is known as corticostriatothalamocortical circuit. In fact, this circuit also, is seen even in conditions such as OCD. So there is dysfunction of this circuit. So this is the corticostriatothalamocortical circuit. So it is centered on the ventral striatum. Again, what is ventral striatum? Again, some of the important anatomical areas one should know in psychiatry. Again, very important. And ventral striatum is basically, it comprises of nucleus accumbens and the olfactory tubercle. So are you able to appreciate now? We, ultimately we'll try to correlate this with the dopamine pathway, with the common reward pathway. So it starts from the anterior cingulate cortex, the ACC, and the ventromedial prefrontal cortex. So it starts from the cortex, it goes to the ventral striatum, so then it goes to the thalamus, and then again it comes back to the cortex. So this is what is meant by corticostriatothalamocortical circuit. And again, it is seen that there is a modulation by the top-down cortical areas. It modulates the circuit. And suppose if the cortex, it is low, the inhibition is less, or there is overactivity of the ventral striatum. So are you able to see what will it lead to? It will lead to impulsivity. So this is again, if you can correlate. So either if there is too little inhibition from the cortex, or there is too high stimulus from the ventral striatum, then it can lead to impulsivity. So this is the proposed circuit for impulsivity. Now let's talk about the compulsivity circuit and the motor response inhibition. Again, it is centered on the dorsal striatum. This is the dorsal loop. You can remember it like this. That was the ventral loop. This is the dorsal loop. Again, it starts from the cortex. It is also the corticostriatothalamocortical circuit. It starts from the OFC, that is the orbitofrontal cortex, that is the PFC. Then it goes to the dorsal striatum. Again, you should know what is dorsal striatum. It comprises of caudate nucleus and putamen. And then it goes to the thalamus, and subsequently again it goes to the cortex. So this is the CSTC loop. Again, it is modulated top down from the OFC, from the cortex. And again, if there is a decrease in inhibition, or there is increase in the drive from the dorsal striatum, again it will lead to compulsivity. So these are two important circuits which one should know, impulsivity and compulsivity circuit. Again, these symptoms, if seen in any disorder, these are the proposed circuits for the same. So in brief, we can say that impulsivity is regulated by action outcome ventrally dependent learning system. So here the person is doing things without considering the consequences, while compulsivity is regulated by a habit system. It becomes more of a habit, which is dorsal. So it is a dorsally dependent system. So this is impulsivity and compulsivity. Again, it is in fact theoretically, again this is very important point which we are going to discuss now. So once our basics are clear, let's come to this. Now it is again theoretically, it is believed, and many postulate that any behavior, it starts as an impulse that is mediated by the ventral loop, and the person reacts to reward and motivation. For example, you reacted to the reward, you got a pastry, and so this basically starts as an impulse. Any behavior, it starts as an impulse, but over the course of time, there is a shift, or the locus of control, it becomes more compulsive, that is mediated by the dorsal loop. So it becomes motor response inhibition, when one is not able to stop a response. So there is actually a shift from the ventral loop to the dorsal loop. And in fact, this has been proposed that it occurs due to neuroadaptation and neuroplasticity. So this has been the proposed mechanism, that how a behavior starts as an impulse, then becomes a compulsive, a stereotypic behavior. And in fact, normally if you see the circuit, in normal, ways, it may be helpful for us, because there may be so many things, which we have in our mind. So ultimately what it does is, some of the things which are not necessary, it makes them shift to the compulsive loop, so that we can focus on some of the other important tasks in our lives. So normally it may be helpful, but if it becomes maladaptive, it becomes malfunctional, then it becomes a problem, and it can occur as a stereotypic or a compulsive behavior in psychiatric disorders. So this is the transition from ventral to the dorsal loop. Now let's try to gather all the information which we have discussed. So we've talked about that the impulsivity circuit, that is from the ACC and the ventromedial prefrontal cortex going to the ventral striatum, coming back to the thalamus, and again going to the cortex. So this is the CSTC circuit for impulsivity. Gradually there is a shift to the compulsivity circuit. Again, let's just look at the compulsivity circuit as well, from the OFC to the dorsal striatum to the thalamus, again coming back to the OFC. So this is something which we have discussed. So this occurs and it leads to a stereotypic repeated behavior. Now also they are regulated by certain other areas of the brain, again important. So also the cognition part, again it is regulated by another CSTC loop, which is from the dorsolateral prefrontal cortex to the dorsal striatum to the thalamus, again coming back to the DLFPC. So this is again, these are regulated by the cognition, by our thinking phenomena, and also it receives, or there is regulatory inputs from the amygdala, again the reward conditioning which occurs. So amygdala, again it also regulates them, and also the memory, the hippocampus also plays an important role in regulating these loops. So this is an important slide, very important. So when you are writing your answers, again this becomes important. So one should also understand the concept, and when you are writing, you should know what are the important things you can write. So this is one important circuit which you should know. Now, so let's just briefly again discuss this. So normally we know that any salient stimulus, it causes, if it causes a favorable outcome, it, again, the behavior is encoded as a pleasurable behavior. So person, thinks that's a pleasurable behavior, and subsequently there is a learning of this behavior, and it is called liking. So you start liking that particular act or that particular behavior, and it is usually opioid dependent. That is, endorphins are released, the endogenous endorphins. Now, subsequently, this pleasurable reward is knowledge and anticipation. It leads to increase in the want to do it, and which is dopamine dependent. So this usually occurs in any salient stimulus. This is what normally occurs. But when this wanting becomes excessive, that wanting becomes excessive, what it leads to? It leads to impulsivity. So this wanting, it becomes excessive, it leads to impulsivity. So any salient stimulus now, it will, without, thinking of the outcome, the person will do it, just for the pleasurable reward. So now the person will do it for pleasurable reward, and what will it lead to? So if you're doing something just for the pleasure without thinking of the outcome, there will be binge. So just like, you'll binge watch sometimes, any series which has come, then there will be intoxication. Person is abusing a drug, will use it to a very high levels, intoxicated, and there will be an excessive behavior. Person will do it excessively, and subsequently what will happen, that if it's there is absence, there will be withdrawal, there will be a negative affect if you're not getting that. And subsequently what it will lead to? Anticipation. There will be a preoccupation of doing it. There will be a craving, or there will be arousal to do it. So are you able to appreciate that ultimately it forms a cycle? So there is a cycle, there is a change which occurs, and person continues doing it again and again. And gradually what happens? It leads to compulsivity. So it leads to compulsivity, and here now in compulsivity, basically stimulus is leading to a habit. Now there is no role of reward. There is no role of reward. You're not thinking of the reward. The stimulus is just leading to that habit. So it is now driven by the stimulus rather than being driven by the reward. So this is the basic maladaptation of the reward pathway which occurs. Again, one should know about this. I hope this is clear. Very important to understand this. Now let's come back finally to the mesolimbic dopamine circuit, which is the final common pathway of reward. So this is in fact, this is seen to be one of the important pathway for reward, not just for substance, so it is important for substances especially which increase dopamine, such as nicotine, stimulants, and even other substances such as alcohol. And it's not just for these substances, but also for any natural triggers. For example, a person you like and the person has texted you a message, so there is this is a natural trigger. Again, this pathway may be again stimulated. If you achieve something, you achieve a gold medal, or you won something, again, in those natural triggers also this pathway is stimulated. Even in orgasm also this pathway is stimulated. So this is a very important pathway, and this is the same pathway which I was talking about, we discussed in schizophrenia, where it would lead to positive symptoms because of increase. So basically from ventral tegmental area it goes to the nucleus accumbens, and there is an increase, there is firing of the dopamine neurons, which leads to reward. So the drugs and certain maladaptive behaviors such as even gambling, binge eating, what they do there is they ultimately come down to this final common pathway. There is increase in dopamine, as we discussed in this pathway, and more explosive than what naturally would occur. So naturally we know that natural triggers would lead to dopamine, but here person is consuming substance, or person is gambling, person is binge eating, so it is more than natural, it is more explosive. The dopamine release is more in frequency and more in intensity is occurring because of these stimulus. So this is the common pathway. Now let's talk about this, the neurotransmitters. So let's try to break it down, this pathway, and let's try to understand how this pathway is regulated, is affected by other areas, other neurotransmitters of the brain. Again, very important. Again, you will find this information useful, again, as mentioned in Stahl psychopharmacology. So let's talk about this, the neurotransmitter regulation of the mesolimbic pathway. So we know that it starts from the VTA, ventral tegmental area. So there is the dopamine neuron which goes to the nucleus accumbens. Then there is GABA. There is GABA neurons which are again important. They are regulating the GABA neurons. They are regulating. So it is also seen in the interneurons. So it is regulating the dopamine release. So this is the basic pathway. We'll talk about some of the important different areas which are affecting. So again, it has inputs from the PFC, the amygdala, the hippocampus. Now can you appreciate when we're talking about the impulsivity compulsivity circuits, where we discuss that the cortex and then even the amygdala, the hippocampus, they regulate. So they regulate mainly by the glutamate connections. So they regulate by the glutamate. So there is a top down, there is a control. Then there are other important areas, that is the raphe nucleus, that is the serotonin. So serotonin also has a role. So it is again giving inputs to both the nucleus accumbens as well as to the VTA. Then there is acetylcholine, again also has a role. So PPT, that is pedunculopontine tegmental nucleus, as well as LDT, that is laterodorsal tegmental nucleus. Again, they are having acetylcholinergic inputs, especially to the VTA. So both the interneurons as well as to the dopamine neurons, there is input, acetylcholine inputs are there. Then also there is the arcuate nucleus, which is basically providing the endorphins, so there is endorphins also which are regulating. So beta endorphins are also there, which are also having a regulatory effect. So this is an important overall, slide when we talk about this pathway. So it's very important, when you write this, when you draw this pathway, it becomes that you understand this, and it's very important not just for your writing. Exams, again, I'm sure you'll clear them, but understanding is also important. So also when we talk about various substances, alcohol we'll discuss here itself, so that you have an idea of how these pathways are acting. And we'll talk about separately when we'll discuss different substances. We'll talk about these effects again there as well. So basically, once a person is addicted, brain no longer the rewarded primarily by the drug itself. So now the drug itself is not the primary reward, but the anticipation of drug and its reward becomes of more importance, and it leads to a compulsive behavior. So the dopamine neurons terminating in the ventral striatum, they stop responding to the primary reinforcer, that is the drug, or for example behavior such as doing gambling. So that the focus shifts from that primary reinforcer, and it shifts, the focus shifts from the to the dopamine neurons terminating in the dorsal striatum, and it begins to respond to the conditioned stimulus. So now